No, I was interested in that. Parking's don't care more today. Oh, yeah. Parking. Oh, parking. Oh, interesting. And there's the back. The back, yeah, there's nothing in the front. Especially if you're new and you don't like the old days. Yeah, I know. So, I'll leave that for you until Sylvia. Okay. Yeah, I'm sure she's just playing this, I mean, again, she's new, she knows. I hope they all know about the back. Well, Daniel got here, says it's in the back, so that's good. Yeah, there's a, the front filled out. I don't know, he said he told people, but I knew that. Even then, I just, so you can be like in places. Yeah. Yeah, I think it's like, oh, happened back, this is back. Yeah, it makes sense, yes. So it just makes it a little more frustrating. You say, oh, there's spots back there. And it's not, right, too little, right, too close. Yeah, that would be good. I know it's kind of, and you know, which will be then. All these things are supposed to be, I went through probation, so that's in places. Is that, did that work? I never figured out. Oh, I was coming through probation. So I tried to help you out. I put down the ones I knew were coming to this. Okay. And then the one that DJ, she's not on the board, so we can go over. Oh, okay. That helps a little bit. So now we need to go. No, yes, we have a quorum. Okay, great. Bus. No, I mean, his father said. Good afternoon. We do have a quorum, so we're gonna get started. I know there's some other people still coming, but apparently parking is a challenge today. Yes, yes, okay. And for newer people, they may not know to drive to the back, so we may be having some, I think we'll have some other people coming in. We'll call the meeting to order and asking the interpreter, you'll come forward and give us your instructions, please.
Hello everybody, my name is Ricardo Garcia. I'm along with Gladys Ramos to the interpreting for this meeting. Instruction starts with the interpreter via Zoom on your computer. After the host activates language interpretation mode, click interpretation icon and select the language that you would like to hear. English and Spanish interpretation is available. Optional. To only hear the interpreted language, click mute original audio. Via phone or your MIDI controls, tap more at the bottom right in the mobile phone app and tap and top right in the tablet app after the host activates language interpretation mode. Select language interpretation and click the language that you would like to hear. English and Spanish interpretation is available. If the icon is not visible, tap the screen to make it appear. Reminder, speak slowly, pause between sentences, speak clearly, avoid interrupting or multiple people speaking, avoid using metaphors, acronyms, slang, or idioms. Interpret signals during the meeting, speak slower, raise your voice, interrupt for clarification or communicate a concern. Acceso al intérprete a través de su computadora. Después de que el anfitrión active el modo de interpretación del lenguaje, haga clic en el símbolo de interpretación y seleccione el idioma que desea escuchar. Interpretación en inglés y en español están disponibles. Opcional, para solo escuchar el idioma interpretado, haga clic en omitir audio original. A través del teléfono, en los controles de la reunión, oprima la opción más después de que el anfitrión active el modo de interpretación del lenguaje. Esta opción estará localizada en la parte inferior a la derecha de la aplicación de su teléfono y la parte superior de la derecha de la aplicación de su tableta. Una vez ahí, seleccione interpretación del lenguaje y elija el idioma que desea escuchar. Interpretación en inglés y en español están disponibles. Si el símbolo no está visible, toque la pantalla para que aparezca. Recordatorio, hable despacio, pausa entre oraciones, hable con claridad, evite interrumpir o hablar varias personas entre sí, evite usar metáforas, siglas, doble sentido o modismo. Señales del intérprete durante la junta, hable despacio, alce la voz, interrumpir para clarificación o para comunicar un problema. Muchas gracias. Thank you so much.
Thank you so much. All right, it's time for the roll call of our members, and I do this by asking you to just introduce yourself and with your district number, the one that you're representing. And we do have at least one new member here, so she's going to have a chance to say a words about herself. And so we'll start with Soledad and then we'll go around.
Okay, my name is Soledad Barragan and I represent the District 5.
Good afternoon, I'm Michael Rodriguez, District 5.
Good afternoon, Delia Rodkin, District 4.
Good afternoon, Genevieve Flores, Harvard District 1.
Hello, Daniel Bednar, District 4.
Hi everyone, Matt LaPierre representing the Board of Supervisors.
Hi, everyone. I'm Rebecca Gregorian, District 4. My first day here. Nice to see everyone. I have a degree in neuroscience. That's my background, and project management. And I'm a mother of 3 boys, 2 of which are on the spectrum. And that's kind of what led me to be here today. Thank you.
Zoe Garcia, District 3.
Michael, introduce yourself, yeah.
Cody Press, Assistant Director, Behavioral Health. Diane McKay, District 2 and Vice Chair, First Vice Chair.
Cheryl Hyman, I'm the chair of the board, District 1.
Good afternoon, Loretta Dennery, Behavioral Health Director.
Margaret Newsom, Office of the County Council.
Thank you, and thank you, welcome to Rebecca, and we have Daniel's been here before, but we do have essentially 2 new members. Sylvie's been here for a little while, and Sylvia already is our secretary. See, we get you right involved right away, so look up. Anyways, yeah, I hope we'll all get to know the new people even better and welcome them. And we should be joining by probably at least 1 additional person in August, and I'm hoping for a second one, so trying to get another person also on that agenda. So that'll be filling the board out quite a bit, which is great. Okay, there were no requests for emergency circumstances, so moving to the agenda. I'll entertain a motion to adopt or change, whatever.
I move approval of the agenda.
There's a second.
Second.
Thank you. Thank you. It's been moved and seconded, and we do, are there any questions to the agenda, any additions? Okay, we're gonna take a roll call vote on this also, so Sylvia, that would be you.
We get to know everyone's name, yeah.
Soledad Barragan.
Thank you.
Daniel Bednar.
Yes.
Andre Pabro.
Probably late.
Nancy Borchard.
Must be late.
Jeffrey Allen Davis.
He's absent.
Okay. Chris Dyer. Genevieve Flores Haro.
Yes.
Myself, Sophie Garcia is here. Rebecca Gregorian.
Here.
It's on the
Yes.
agenda. We're waiting for the agenda. We're waiting for the agenda, so it's yes or no.
Abstain.
Oh, you can do that.
And Supervisor Matt Lemire,
Yes.
Naomi Marco. Absent. Diane McKay,
Yes.
Dahlia Rockин,
Yes.
Michael Rodriguez,
Yes.
and Marlene Torres. And Cheryl Hyman.
Yes, that motion passes, thank you. Now we're moving to the approval of the minutes from June 16th meeting. Again, I remind you that if you weren't here, but you've read the minutes and you feel confident, you can also vote yes or no for them. So entertaining a motion,
I move approval of the minutes.
I'll second, Sharon.
thank you. Been moved and seconded, are there any corrections or additions people have?
I had one correction.
Okay, go ahead.
I was reading them and it just said that I had a concern about the ice raids. And I just wanted to make sure that the correction was that I actually had proposed the psychological first aid responders. So if that could be added, I appreciate it. Thank you.
Okay, sure, we can add that. Oh, sorry.
If I may, these are the general meeting minutes from June 16. Your comments were in the executive meeting from last week, because I just reviewed that.
Oh, okay, thank
So
you.
that was just last week, so these are from last month.
Okay, thank you.
Okay, any other corrections or additions? Any seeing none, again, Sylvia, you have to do some roll call, sorry. Part of your new position.
Okay, and these are for the.
This is for the minutes, approval of minutes, right?
Okay. Helena Barakan,
Yes.
Daniel Benmar,
Yes.
Nancy Borchard. Absent. And Andre Butler is absent. Jeffrey Allen Davis is absent. Okay, Genevieve Flores Haro,
Yes.
yeah, it's yes for myself. Rebecca Gregorian,
Abstain.
Supervisor Matt Lemire,
Yes.
Diane McKay,
Yes.
Dahlia Rockin,
Yes.
Michael Rodriguez,
Yes.
and Cheryl Hatman.
Yes, that motion passes, thank you. Okay, we're moving on to public comments. Do we have any public comments from the, in the room? And I'm not seeing any on Zoom either. And did you receive any?
Just the two that are attached.
The letters, yeah. Yeah, so I did receive those two letters that we attached to your packet, so you'll be able to read them and we will respond to those two young people, invite them to press attend one of our meetings. Okay, moving along to chair announcements. I do have a couple of things. I wanted to just mention about the room order, because I know that seems kind of confusing, but we are sitting, the offices are sitting here and this, and Loretta, this, and Marty, because we're the ones who were then on the camera. What I noticed when I was home ill watching the meeting was that the camera's still. So anybody sitting on this side was on the camera the entire time. So if you're checking your, you know, if you're going through your email or whatever, it's obvious. So I thought it's only fair that we sit on this side because we do most of the talking anyway. Plus we move the speaker microphone also over here so that whoever's speaking to us, presenting, is on camera. Because I watched our whole meeting with great presentations, but I never saw who was doing it, and it really is disconcerting when you're trying to watch and you can't see the person. So anyway, that's the change there. I wanna also announce that I have appointed Naomi Marufo to be the community at large member, or the member at large, sorry, of the executive committee. And that is an appointment by the chair directly, so She attended her first meeting, even though she was official, last month, and she will be continuing on as a member of the executive committee. I just want to remind everybody that if you don't get your packet Thursday night or Friday in the email, please be sure and check your junk or your spam, because we're having a little issue with some people not receiving it, and yet it looks to the staff as if it has gone to them. So it may be that it's going somewhere it shouldn't. If that's not the case, then please let the staff know. Please give Celine a call on Friday and let her know, so that she can still get one to you and correct your email if in fact we don't have it correct. So just so we'll know, because we've had this problem, and it's probably because of the change in administrative assistants, but and new people. So we just want to make sure we have everybody's correct email. Also just important to read your packet when you get it, as much as you can, because some of these presentations are quite detailed, but if the packet contains the presentation, it gives you a heads up, so you're not just listening to it firsthand for the first time when you're here in the meeting, but you have a chance to review it, and therefore would know kind of the questions you might wanna ask during the meeting. Oh, and the work groups, I'm hoping, will start again in September. We have not been able to do much with them due to the fact that we had so many changes of members on the board, and so we're hoping that next month after our orientation meeting, we will then be able to reform, get the work groups going, and really start again new in September. The bylaws, I also want to announce, we have submitted them. They've gone through county council. I think we're ready to move forward now. They do have to be translated before we can actually bring them to the board. So hopefully at the next meeting, we'll be able to finally review the bylaws.
Plan is the plan.
Yeah. Yes, and I think, oh, and then, yeah, I think that's it for announcements from me. Director's report, Dr. Jenner.
Right, thank you, Chair. This is my first day back from vacation, so I'm going to defer to the written report. And should anyone have any questions or concerns, myself or my assistant director, Mario Praza can update anyone on any questions. Just related to the comments about the technology setup, I did want to update folks that we are still in the queue for the room upgrade. I signed invoices before I left for vacation, so I know it's happening because I paid them. So eventually, the goal is to update this room to where we have, similar to our conference rooms upstairs, where we have the two-way video conferencing technology, so that folks will be able to see the entire room, and it won't be tiny little people, and we won't have to rely on this little owl system. And we're also upgrading the microphone system. So given the size of this room, it is gonna take a little bit, and it has been kind of a comprehensive evaluation from the IT folks to get it updated, but it will be happening soon. So thank you for your patience. Otherwise, if there are any questions I can take about the director's report or any concerns, then at this time.
Back.
Thank you. Yeah. Are there any questions for Dr. Duttering or any specific comments you want to make? Wow, okay. I guess everybody thoroughly read your report.
Yes,
that's a
And also to note, I do have to step out at about 2:55 for a state director's call with the Department of Healthcare Services that scheduled at the last minute, so. But Connie will be here should there be any questions.
Okay, thank you. Okay, we do have two presentations today. So the first one is from Sarah Sanchez, and her official title is Critical Care and Navigation Services Division Manager, Chief, sorry, I didn't mean to. Yeah, okay. So we're excited to hear, last meeting, we did hear about the new mobile unit, there's so much interest, so that was really important that you come and give us an update, so the board can really hear more in depth.
Great,
Thank you.
thank you very much. Good afternoon, everyone. Thank you once again for the opportunity to come and speak to the great work that's in directly for our community. I'll wait for the slides to come up.
Yeah. Yes.
Okay, well, again, thank you very much for allowing me to be here this afternoon. So very much excited to talk about our mobile behavioral health services van. Next page, next slide, sorry. So this is our team. We branded our name with Wellness on Wheels. As you can see, it's a mobile vehicle that is all in one. So this comes out of our Mental Health Services Act innovation dollars. This was in the works for many, many years. We had stalled given that the vehicle had not yet been ready, but we did a soft launch. Goodness, I'm trying to think back. I feel like it was already years ago in January of this year. So on your left, you can see the pictures of our staff. So very much excited to talk about just all the services and services provided. So next slide, thank you. So in this behavioral health mobile van, what we're providing are screenings. So we conduct mental health and substance use screenings. So we are located at different locations at different venues. So our focus is to focus on remote areas where it's difficult to access our outpatient services. We started with, sorry, this microphone. It seems like it's cutting off.
It's our fussiest one.
Good to know.
It's not
Good to
you.
know it's not me.
It's not you.
So we provide screenings, both mental health and substance use, referrals, linkage, navigation to appropriate services and resources. Also, we provide wellness services. So if the individual family is coming in need, we provide therapeutic intervention services as they're getting situated, referred to a treatment provider for the ongoing treatment. Noted here, there's future state. So as noted in January, we did a soft launch as we wanted to ensure that we got this vehicle on the road as we're acquiring all the needed staff. We will be providing future state directed healthcare prevention screenings, hypertension and diabetes monitoring, health education and telepsychiatry appointments. So very much excited for that. Not quite there yet, but going to get there. And then of course, the case management and case coordination of services. And then we also provide Narcan kits and fentanyl test strips. Slide. So the current structure is we have a behavioral health clinician, an intensive services coordinator, which is a case manager, a alcohol drug treatment specialist, and a peer support specialist position. So the goal is to have staff that are both bilingual in English and in Spanish. And then we actually just had a nurse start most recently, and future state will have a psychiatrist. So again, you may wonder how we're all gonna fit everybody in the vehicle, but we're coordinating to ensure that we're either at the same location or expanding the outreach and the engagement to the different locations. So currently, we partnered up with Poder Popular in Santa Paula, St. Francis of Assisi in Fillmore, and Swami Justice Center in Oxnard. We're meeting with our different local community partners to identify different locations, different venues where they see it would be beneficial for us to engage families and individuals. There has been an ask to go out to the schools. The only item with that is we serve families, so if it's a minor we have to have that parent present, given the services that are being provided, so. We're really working on trying to identify how to best provide the services, so truly thinking outside the box. Most recently, we've seen where families are not necessarily wanting to go up or approach the vehicle, so we're looking at how to best provide the resources. So some community partners have opened up their doors and we go and are co-located at their facility to be able to provide the services. So it's very much an opportunity for individuals, again, not necessarily needing to meet our level of care, but that engagement and that support and that intervention on the spot as we're getting them the needed supports and resources to the longer term treatment if that's what is needed. So
And I know that schools require parents, but the community colleges have expressed great need. Do you coordinate with them at all?
yeah, I think it's right now we're open to coordinating with everybody. So if there's contact individuals or community partners that is beneficial, we'll definitely reach out. Right now, we're again identified locations that have opened their doors for us that we're attending on a regular basis, but we want to expand our reach. So definitely. And then next. So just a snapshot of the services that we've done since January, since doing our soft launch. And again, this is up to May. Given we're now in August, we've actually expanded more. We've done the different events. So again, it's depending upon what the benefit, what the need is. So we can do outreach events, so provide workshops, provide individual resources, services at the moment. It really allows the innovation dollars, it really allows us to think outside the box in the services that are being rendered. Given the need of the community, given the need of, each city has their own specific needs. And so we do our best to tailor it to ensure that we're providing the needed resources and the immediate support. Here is sharing again some of the locations that we attend on a regular basis. Again, identifying different locations that are remote areas. We also go out to and join our backpack medicine team, so at the local encampments. Given that team, which as well includes our RISE team, is very quick to go to the different encampments, we encourage the individual that is willing to engage with us to, we walk with them to the vehicle to be able to receive that more engagement, that more involvement in case management, so that we can support them with resources. So our team is as well trained in our HMIS system, so it's that centralized database to be able to identify housing resources for them. So we really want to begin from that initial point of contact, providing the much needed support and services as we're looking at how to best support them and what level of care. Any questions?
Any questions or comments? Matt?
Thanks for the update, Sarah. I know since we've, with the recent federal immigration raids that have been happening recently, that you've been kind of keeping this mobile van into kind of over here. Can you talk a little about how you're trying to address the challenges that we're seeing with the impacts of the raids on the impacted communities?
Yeah, thank you. We actually were in a meeting with our assistant director on Friday to talk about the different resources and leveraging the resources. So we are open to working with different community partners that are willing to have us be there. I know that, again, most recently, we've seen lower volume of families that are willing to approach our vehicle. So like Poder Popular out in Santa Paula has allowed us space in their location to be able to engage families, so not to bring attention per se. We're really working and identifying just the different locations, because what we don't want to do is bring attention where it's not needed. Our focus is to support families, whether they're experiencing impact of the ongoing concerns that are happening now and being able to engage them in the community. So we really welcome, our community partners that have locations or suggestions as to where we can be able to best support our families in need and be able to engage them there. So it's an ever evolving process. I know, most recently we partnered, with our local Boys and Girls Club as well to be able to, provide a workshop.
I was wondering how people know that you guys will be there, because I assume that it's not always the same location.
Well, we have reoccurring locations, so on the slide, it'll note there the reoccurring location, so we really depend on the community partners that are able to share with them this resource. Because again, all of it relies on the trust, right? That trust to say, you know, these are trustful partners that are here to provide the services, to engage you in your time of need and identify what resources are available. And then, again, looking at what the volume is of families, individuals that come, then it's a place that we continue attending. And as we expand where, there's other locations that we can attend and, you know, we wanna mobilize the resources. So the event itself is not needed to deliver the services. So if we have more of the requests coming in, we ensure that we have the staffing needed to be able to support the community.
So go ahead.
If ICE is able to obtain medical records, can families come in on this, and get the treatment they need?
So I wanna be mindful, again, given that this is an innovation plan, it's really a services that is outreach. So it's outreach, engagement, we provide resources, services, and if the family is not comfortable in sharing with us information, that's not gonna be a reason why not to render an individual services.
So they can come
Just
on
like
the. Okay. that's
Yeah,
fine.
so it's not gonna be where we pause services or link them to resources because they're not willing to provide identifying information.
And then what can we do as representing our districts to,
I think it's always beneficial to provide different community partners that are willing to partner with us. Provide us contact information and we'll be glad to connect with them, provide them an overview of the resources and the goal and the purpose of the services that we provide through this program, because again, it's not necessarily the van itself, but that the services are mobile.
I think that's confusing for us because I think we think as sitting on the board that you guys do everything. And so like being here, we want, like, I wanna be able to help support that, so I wanna know like what I can do sitting on the board. And getting back to my supervisor, how we can, you know.
So I think, Sarah actually just answered that, really is just referring people to us, because we are the ones who can figure out which delivery system is most appropriate. Again, behavioral health, county behavioral health is one piece of the behavioral health continuum. Our partners at Gold Coast Health Plan have been doing a ton of resources also in response to these, incidents and all of the things happening. Our community partners and at Kaiser and other health systems are also responding in different ways. And so rather than trying to figure it out for yourself or even have our community members try to figure out, that's where we come in with our patient navigators and our services to help figure out what's the appropriate level of care for folks. So the easiest thing to do would be to connect them to Sarah and her team, and we can kind of take it from there.
Thank you, Dr. Denning. Yeah, this opportunity is really, it comes out of the innovation plan, so it's really more outreach and engagement and linkage to resources. So it's not may not necessarily be ongoing treatment, right? Because it might be an individual that has a crisis in hand or a situation that is not necessarily a long-standing mental illness or substance use. So we want to utilize this resources as an opportunity to provide that guidance. And when I say, reach out to us, it's the community partners, those that have locations or those that know where we can best be able to engage families, because I think that's been one of the items. Connie has initially when we launched, we went out to the community to talk to our community partners about, this great resources, and then that's where it started to be able to identify the location. So the more individuals that we can connect with, it's beneficial so that then we can be able to provide the services.
Chair, if yeah, go ahead.
I think one big, very important way that you as our board members can help us is if you can please share our accident crisis line. Because in that number, not only do you call for accessing our services or crisis, but also information, as Dr. Dillon said, and or linking them to the most appropriate organization or services in the community. So that access line for us is very critical, so we can coordinate efficiently all the resources that we have in partnership with the other community folk. So I think I know Genevieve was this great meeting that took place last Friday, Supervisor Lopez. The big barrier all of us are facing, not just county, is trust. Almost every organization, and it was a pretty full room, sharing with Dr. Dannering, that trust, they don't trust. Cause they've seen photos of people talking with eyes, they've seen all these things that are happening, so that is the biggest barrier, I would say, Sarah, you and I heard it over and over again. So we're trying to really implement these strategies, innovative strategies, so hopefully we can build trust and rapport and help people get access to our services. So please, our access and crisis line, you can help us, that'd be great.
Connie, that line's 24/7, right?
24/7, sir, yes.
You wanna give that number?
Yes, so glad I'm being put on the spot. I have
Oh,
to
I
memorize
saw
it, no, I'm just kidding. It's 1-866 998-2243, but I'm gonna double check. And I see nods, yes? Okay, yes. Yeah, just
Say it again, you did it very quickly.
It's 1-866 998-2243. And yes, that is our access to services, our crisis service line, that's 24/7. So we have English bilingual staff and as well interpretation services on the spot if it's needed, if we don't have a staff that speaks the caller's preferred language.
Other questions? For Sarah? I did have one, I've been in contact with, someone, well, Martinez Bravo, we've done some friends at Field Workers, and, I don't think she was familiar with the fact that perhaps the van goes places. So, you might wanna, I mean, I can refer to you, or you can, whatever is easiest.
She was at Friday's.
Well, it seemed different, yeah, cause,
She was on Friday, she wasn't on Friday.
okay, so much. Okay, but it was a big meeting,
I
and
can reach out.
yeah, I think some of it maybe got missed.
She wasn't there on Friday, but her staff was there. I think Christine was there. Her staff started the program.
Okay, Genevieve, do you have anything you wanna add, or about what she's the mowing unit and, no, okay. Trust, yeah.
Yeah, I mean. Just on the trust piece, so you have 361 farm workers that were picked up on July 10th. And you have ICE, we've had families of the folks that were picked up that are saying that ICE are going to their homes after the fact. And one of the things that I had shared at the meeting on Friday is that, we've been working in Ventura County since 2001. We're doing grocery deliveries and we're literally at people's doors with their groceries, and people are saying, don't come here anymore, lose my number, lose my address, because they are so worried about their safety. And again, these are people that we've worked with again for the last 25 years, and that's the level of fear, that's the level of concern. And that's with a community-based organization. And so with all of my respect, when you have government entities that don't have that level of connection, that just widens the gap. And that is what this federal administration is sowing in our community. That's the cruelty, and that's the point, right? That's the point of all of this. And this is what we're dealing with, and these are the gaps that we're gonna have to work with. And so, again, with all of my respects, really looking to leadership, Dr. Johnson put out a call to the department chairs, to really be innovative, to really be creative about what we can do here in Ventura County. Because like many other things, Ventura County is the bellwether. The nation's gonna be looking to us. I had a reporter tell me that what happened on July 10th is the largest raid in California's history. Period. And so what we do moving forward is gonna set the tone for what other communities do as well. And so the ball's in our court on how we respond and what that looks like. And we get to be innovative, we get to be creative. And I'm happy to be a thought partner in that. But our community is hurting.
And when you lead.
Well, thank you. I think that's one of the reasons this came up was the concern, obviously, and wanting to see what can be done. So I appreciate the fact that you had that large meeting and people are taking it very seriously, obviously, and trying to have some innovative ideas on how to reach out, but that we're, as a department, doing certainly some good work. In addition, just the outreach van is such a great idea, the mobile van, and I wish Naomi was here today because she talked at our executive committee meeting about how it had come to her agency in Santa Paula and kind of who had come and who they had reached out to in the services. So she gave kind of a first-hand report of it, and that was very encouraging. Knowing that the word will spread and you'll be reaching many more people than you are at this point, but that's clear that will.
Thank you. Yes, I agree. The sensitivity around how to engage families and be sensitive, understanding that we're a government agency and our staff are very mindful of that. So we thank you. We thank you for your input, Genevieve, and everybody, because we do want to be there for the community, but we also understand the climate we're living in. So thank you.
Thank you, Sarah, for your report and for letting us know what's going on. Any other questions before she leaves? Okay, all right. We have a second presentation today. It's about our needs assessment, HMA needs assessment report. Allie Franklin, the project director, is here. Going to give us now I know this is somewhat lengthy, but this is so important that I felt like I didn't want to cut them back too much in terms of time, because there's just so much for them to tell us, and we actually were so, as a board, instrumental in getting this started, so it's really important, I think, that we were able to get a feedback to them on what they're affecting. Thank you.
Great, thank you so much. Hello, everyone. I wanted to start by giving a special shout out and a thank you to John Polich. I know he's not able to be here with us today, but was instrumental in helping get us connected to all of the people that we needed to speak to throughout the assessment. And then also a thank you to the Ventura County Behavioral Health, both the health plan and the finance department, for helping us get some of the data that we needed. And it was very independent. I want you to know they actually didn't see the report before it was done or anything else. Similar to what you would do with an external quality review, Ventura County provided some data for us so that we were able to see what was being provided through the health plan. I wanted to call out another piece as we get started that Dr. Dennering talked about, which is that this assessment is looking at all of Ventura County, not just the part that is covered by Medi-Cal. And so you'll hear me talk about the difference between Medi-Cal covered lives and other people who are covered by either other health plans, commercial insurance, and uninsured folks. And so just really want to tee that up as we get started. And so if you can go to the next slide, just how we'll spend a little time together. We want to make sure to share with you a little bit around the project background, an executive summary, and then some pieces around the methodology, because we want to kind of build how we got to where these conclusions are. But then the place that we really want to spend the most amount of time is talking about gaps and recommendations. I have on the line with me an actuarial specialist and an epidemiologist who can help us if you have any questions around some of the specific tools that we used. But that's how we'll spend a little time together. So next slide, please. So project background, this really builds on, you had another consulting organization get started and do some pieces around community engagement and finding out how people, what their perceptions were. And so we brought in the piece around the qualitative and quantitative. And so really pulling in the data pieces of this analysis to be able to look and to help you understand what your data says around utilization patterns here in Ventura County and where there are potential gaps and also where there are some strengths. We looked at previous reports and findings. We created 3 separate tools for you, a geospatial map, a prevalence model, and a utilization model. And I will share a little bit about each one of those three pillars together with you today as a part of our presentation. You can go to the next slide. So the piece people always want is cut to the chase. What'd you find, Ali Franklin? So that's what we did in our executive summary. We'll go into a lot more detail about these findings, but I wanted to start with, first of all, there are a lot of strengths around BCBH. So anytime I talk about BCBH, that's talking about covering Medi-Cal, covered lives, and also crisis. When we looked at the previous report, the external quality review that looked specifically at the Medi-Cal behavioral health plan, called out some incredible strengths, well-positioned for systems transformation and sustainable growth. Using real world data and population insights to help guide decisions. Strong partnerships across healthcare, community, and emergency sectors. Embeds cultural and linguistic equity in services and planning, and engages stakeholders and individuals with lived experience in the care that's provided. So those are some exciting things that I think is important to talk about what is going on in Ventura County from a wonderful standpoint. Even as we talk about gaps. And so when I'm talking about, so that is specific to Medi-Cal covered lives. When we look at the gaps, this is going to be your larger community. And so one of the pieces is that there are few resources available in central and eastern Ventura County. And that's specifically when we look at the map is that wider population beyond Medi-Cal, so Medi-Cal plus, right? And so you do have people who are very low income, but maybe they don't meet the income requirements around Medi-Cal, who have needs. And so really looking at what's going on in East and Central County, we also know it's really important to make sure that all people in your community get care, or else Sarah will see them over on the crisis side. And so if we're able to support people proactively upstream, then they don't end up in a place where they need to use the hospital or they come into crisis care. There's a lack of inpatient psychiatric resources within the county, especially for youth. And so we know that that makes it more difficult for families when they're thinking about being trained and what to do and how to support this person as they're discharged. We know that it can become a burden for people to go and visit their loved one when they're out of county. And so we actually have some numbers that we'll share a little bit about that. The other thing is that, and we know this, your BCBH is dealing with a lot of shifts in funding and in kind of changes to the benefit from a larger California standpoint. And so there's a need to be able to be very nimble and have a forecasting tool at your fingertips to be able to be responsive to all of the shifts and changes that are going on from a state standpoint. And because EQRO noted how data driven and data informed this health plan is, which is a wonderful strength, being able to give you some more tools to have at your fingertips to be able to proactively design what's going on. Because as you all are very well informed, planning something, getting something started takes time. It takes being able to plan that in advance. And so the more you know earlier and thinking around what your future needs are, the better able you are to be responsive to needs as they arise. And then the last piece is this mismatch that we found between public perception and access performance. EQRO actually called you out for having an incredible a positive, having a higher penetration rate. More people are getting care from Medi-Cal covered lives in Ventura County per capita than in other counties. Which means that access is better, more people are getting care. And yet when the previous consultant firm talked to people, there's a sense that they aren't getting the access that they need, that people are feeling like it is hard for them to get access. And so that mismatch tells us a couple of things, and we'll dig into that when we get to gaps and recommendations, but wanted to call that out kind of as a top line. And I want to keep reminding us all that we're not just talking about your Medi-Cal covered lives, we're talking about all residents of Ventura County. Okay, our next slide. We're going to talk a little bit around methodology. We can go to the next slide. What did we do? First of all, we took a look at all of the previous, two of the previous needs assessment one in 2019, one in 2022. We invite you to read the report where we actually went into detail around what those findings were and summarized the findings. We also looked at your external quality review, or you'll hear me call it EQRO often, that who came and did a review for fiscal year 23 to 24. Anytime you hear me talk about EQRO, that's talking about Medi-Cal only. The behavioral health plan's job is to provide care for Medi-Cal covered lives, and EQRO's job is to come and make sure the health plan is doing what they're supposed to do around specifically Medi-Cal. And so that's where you may have some wonderful numbers that are saying you're doing a great job reaching your Medi-Cal covered lives, and people in your county might still be feeling that they're having access issues because it could be part of the population that's not covered by the Ventura Behavioral Health. Okay, if we want to go to the next slide. What you heard from EQRO are some incredible strengths, and many of those strengths are ones that I listed in the executive summary, so I won't repeat those. But one of the things I wanted to call out was a comprehensive approach to addressing cultural and demographic needs across the county was called out as a real strength. And so we don't often see that. We actually sometimes, when we're doing needs assessments in communities, find that as a gap area. And so for EQRO to say that there has been some specific efforts that have been done, and to call it out as a strength was actually really exciting for us as we were looking through the EQRO report. We talked about the penetration rate being higher than average here for most age groups, and also quality improvement efforts around data analysis, peer staffing, and electronic health record implementation and interagency. As we talked to different agencies, particularly we spoke with schools and some school districts, what we heard was a great sense of partnership between VCBH and school districts and between providers. So I think that's important for you to know. Some opportunities that EQRO noted was enhancing of tracking systems, analyzing your high cost member trends, continued attention to improve operational efficiency and service delivery. And so really, and also looking to complete Medicare certification to reduce denied claims. So those weren't our findings, those are just a note from what the EQRO found when they came through. We can go to the next slide. The next thing that we looked at were some publicly available scorecards about Ventura County as compared to the state of California. And what you'll notice is that of the 12 metrics that we looked at, 6 of them, Ventura County is doing better. And so sometimes lower means better, sometimes higher means better. The ones that are green and say yes mean that you are actually doing better than the rest of the state, than the state average in these particular areas around unhoused, around age-adjusted ED visits due to drug overdose, around hospitalization rate due to drug overdose, around age-adjusted death by suicide rate, adults with health insurance, and people with public health insurance only. And so these are the areas where Ventura County is outperforming the rest of the state. So you know, what I would say is that's a mixed bag, because of course you'd love it to be better than 50%, and 50% is pretty good because there would be some communities who wouldn't be above the average in any metric, particularly when you have so many counties in the state of California. We can go to the next slide. Let's take, we can go to the next one. So if you were here for my interim report, you heard me talk about a GPS. So I'm a nerd, I'll share with you that in order to do a GPS, you need 3 points of information. One tells you where you're at, another one tells you where you're not, and another one tells you where you're moving to. And so we took a GPS approach to this needs assessment. We looked at the socioeconomic status index and provider resource mapping as a part of a geospatial map. That was 1 point that we created for you. We looked at the prevalence model. What's the population doing and how likely is someone in your population to have a behavioral health condition overall? And then the utilization model is really looking at what are the patterns of use within your community. What you'll notice about a prevalence model versus a utilization model is that you would always have higher anticipated numbers in a prevalence model, because this is if everyone who needed care chose to get care and had access to care, so a bigger number. Whereas utilization says this is how many people are actually using care, so that would be a smaller number. How you begin to see what is going on in your community and what your needs are, is that you look at all three of them and begin to say, okay, where are the people, where are the resources? What might we need top line if every single human who was eligible for them got care? And what are we using so that we don't create too many resources, but we also don't create too few? And so that's really what this slide is telling you. And we created three of those tools, so geospatial map, prevalence model, and utilization model for you. And those are all part of the scope together, and they belong to you now. If we want to go to the next slide, these are some slides that you've seen before. This is actually a screenshot of an interactive map. This shows you all behavioral health providers in Ventura County, whether they're for Medi-Cal or for non-Medi-Cal. And what you'll notice is wherever there is a little box or a triangle, that's where there's a provider. And I'd like to point out to you how many spaces within your county don't have any box or triangle. And so that's where, and the map that we got, and I think this is important, is that the U.S. Health Resources Services Administration, people call it HRSA, maintains a database of every single community in the United States and has designated 2 areas within Ventura County as health professional shortage areas. One of them is in Oxnard, and that's about low income, low resource support, and the other is Santa Paula, and that is about low resource, having a low number of providers per capita. And so the federal government, the HRSA, takes a look and says, these are areas that you are short a certain number of providers per number of residents in your community. The other thing that you should know is the color gradient on this map is that where it is orange, those are folks who are more socioeconomically disadvantaged. And as it gets darker blue, those are folks who have more resources and more support. Where it is kind of light, kind of gray or white, while it's within your county boundary, those are in the middle, right? That's around the median or the mean. But it's important to know, just because that's not orange, that doesn't mean you don't have people who are low income or very low income. It just means that the number of people who are low income or very low income is about the same as the folks who have maybe a little bit more. So there are still a lot of needs in your central and eastern part of the county. So it's important for you to make sure that you've got enough resources for those folks as well, so that they don't end up being in a place where their behavioral health conditions cause them to fall into the lower income and more disadvantaged areas. We can go to the next map. This one, you'll see, these are the resources that are either directly operated or part of the network for VCBH. So this is support that's available to people who are covered by Medi-Cal. The other thing, and I was so excited to hear about, I'm gonna call it WOW, the Wellness on Wheels. I was sitting there writing wow as I was hearing Sarah talk about it, because that actually allows you to bring crisis services to other parts of your county, even though you're not building more brick and mortar in a particular area. So you're actually already addressing one of the things that we found as a gap area. So it's always fun to come and identify a gap where you already have a solution involved. These are maps that you've seen before, so I'm not gonna go into a lot of detail, although when we get to questions, we can always come back to them. We can go to the next slide. So we looked at some data, and this data comes from the this one comes from the Department of Health Services at the state of California, and it looks at your psychiatric inpatient admissions by age group. And you can see here that the age group between 18 and 64 had the highest number of psychiatric inpatient admissions for calendar year 2024. And you can see the difference. The orange or the top number shows you distinct members, and the blue shows you total admissions. So that shows you that you have some individual members, and that you have some folks who might be re-hospitalized, or they may be coming to more than one time. Many admissions were for that 18 to 64 age group. Both youth and adult populations had higher rehospitalization rates. And so that same bed ends up not being able to go as far because someone's using it more than one time. We can go to the next slide. Another thing that we saw, and this shows you the distribution of where people who are from Ventura County are going to the hospital. And you can see that the vast majority of folks are going to Aurora Vista Del Mar. And the second is the Ventura County Medical Center, and then there's a smattering of other places. And so these are the California all-payer databases. So this is not just Medi-Cal, this is all Ventura County residents. Yes,
So when you say Ventura County Medical Center, that's the main hospital and Philmont Psychiatric Hospital.
correct. So the question was, when you say Ventura County Medical Center, that's the main hospital and the psych unit. The answer is yes, although here is the caveat to that. These are not all admissions of any kind. These are all admissions where the chief complaint or the primary diagnosis was a behavioral health condition. If that's helpful. Great question, by the way. Our next slide really talks around what is the gender distribution for inpatient care at Aurora Vista Del Mar, and also the age of the time of admission to Aurora Vista Del Mar. And the reason we selected that one is that it provides care for all age categories, whereas the Ventura County is unable to care for children. And so selected that. And so you can see there is a slightly more admissions are female versus male. And 62% of these ages that were hospitalized were between the ages of 20 and 59 years of age. And so that goes back to that age group that is kind of a key group, a key constituency. The second most common was the 10 to 19-year-old. And again, those would be kind of in that next age group. Okay, we can go to the next slide. Couple more data graphs before we move on to talking about the findings. And this is among Medi-Cal beneficiaries. So this is important. This is where this is not all Ventura County residents. This is folks who the health plan, Ventura County Behavioral Health Plan paid for, and that's where we got the data. What you're seeing is that about 50.3% of inpatient admissions occur at hospitals in other counties. So the single most common place for someone to be hospitalized if they're Ventura County Medi-Cal covered life is not in Ventura County. That's important. And so understanding, what kind of resources and supports might be available, both to prevent a hospitalization if possible, and then also how do we make sure that we're providing additional supports to people to mitigate the risk that happens when someone has to go out of county. I'm gonna go to the next one because it tells the story even more. So this is where you'll see the blue line, or the blue bars are total admissions by age category. And the teal line, that little bit shorter green line, are out of county admissions by age group. And you will see that trend line, that's kind of a tan line that's going up and down, is going to show you the percentage of the age group for admissions that end up going out of county. And so some things to know, the youth population is somewhere around 73% of youth are being hospitalized outside of the county. Actually, it's even a little higher than that, it's 78%. Are being hospitalized outside of the county. That's a lot. That's hard. That's a burden on families. And then another population that's being hospitalized a lot out of county are the folks who are aged over 65. Now, both the youth and the over 65 are smaller numbers, but the impacts are high. We'll move to the next piece. And so this is, we talked a little bit around, we gave you a prevalence model and we gave you a utilization model. So this actually looks to see what sort of resources you might need in order to be able to support the population. And this is specific to your Medi-Cal population. And so what it shows is the utilization model and then this high level model forecast. It's why you need both models to tell you the story, because what you'll see, and I'll just pull one out. So when you look at inpatient beds, which would be the second to the last one, it says that your current utilization is about 40 inpatient beds. That your future forecast suggests that you might, looking at your utilization, you might be between 41 and 45. So there's a little bit of growth that you might expect, but you could be on the hook for, if everyone who needed care agreed in care, you could be on the hook for up to 53.2 beds. What you don't want to do is build to the 53.2 because you'll have unused beds. But you might not want to build to the lowest number, which is the 40, because you, or 41, because you actually would be under resourced for what you might need. And so that's how you look at this graph when you're looking at it. And that's how we looked at it when we were thinking about the utilization model. And the last one is service utilization by age group. So one more slide, there you go. And that is doing the same thing, but it's really looking at just the utilization. And now it's looking at it by age groups. So you've got youth, your youth and transition age youth, you've got older adults. And then you look at and say, what is the total change? Are there more resources needed? And what is the percentage of the change? Some of them you need more, some of them you're okay, you can hold steady. And there's a range between low and high, and you can find a sweet spot somewhere around the low and the high. Wouldn't recommend that you go to high, might want to go a little bit more than the low. Okay, so the last piece, the part I told you we'd spend, a good amount of time on, is our gaps and recommendations, and you can go to the next slide. So there were 4. One, and this goes back to, we're talking about all of Ventura County, not just your Medi-Cal covered lives. And that is that your Santa Paula, Somis, Moore Park, and Camarillo regions have limited access to behavioral health resources, which means that they may be using more crisis because things get more severe for them before they're able to get care and resource. And so there is an elevated emphasis on Oxnard because of the socioeconomic disadvantage in the region. But it's also important to make sure that you're thinking about those folks who have low income and who have difficulty getting access to care in other parts of the county. And so some recommendations around that might look to expand the network to include more services for Medi-Cal members in Santa Paula and Simi Valley regions. Might be thinking around, I love the mobile van is a wonderful idea. Looking at those kind of things, but also potentially working together with the school district. And we shared with you a model that's being done in Sacramento that leverages, it actually partners federally qualified health centers, FQHCs, with those school wellness centers and allows them to build FQHC and be paid in a sustainable way, in a long-term sustainable way, to provide services not only to the youth who's in the school, but also to their family members, because people have to bring their kids to school. It's a great place to say you can also get your health care back there.
Can you, when you're using all those acronyms, the abbreviations, can you explain some of what they are? I mean, just at least say the words out, because we have so many new members here.
Absolutely. So,
Thank you.
and I did a little, but I will, a federally qualified health center is an FQHC. Is that the one you were wondering about?
Yeah, well, I meant to say it before you started, actually, just in general, because I
Sure.
just think there's so many new people, it's hard to.
Absolutely.
You think of what does it mean? Yeah, thank you. Okay.
Yeah, so, and just for you all, anytime I say VCBH, Ventura County Behavioral Health, that's your Medi-Cal. EQRO is the External Quality Review Organization, and FQHC is Federally Qualified Health Center. But thank you, I will always try to remember to say those each time. And so that gives you the opportunity to think about how do you expand services even to your non-Medi-Cal covered population, but to your low and very low income, or kind of those folks, maybe people kind of on the cusp of qualifying for Medi-Cal, but they're still in need of those services and they need help so that they can hopefully not need to qualify for Medi-Cal. Gap two, we can go to the next one, great, which is approximately 50% of inpatient psychiatric admissions are happening outside of Ventura County. And then, as I pointed out, 78.5% of youth inpatient stays are happening outside the county. So consider contracting with as an inpatient psychiatric provider who could provide services for more youth within the county. But the other piece is that it may be difficult to expand those resources for youth from an inpatient standpoint. Those are always some of the hardest beds to be able to get more of. And so consider expansion of intensive youth resources such as day treatment or partial hospitalization resources to be able to provide what I would call a step down or a step away, like a step instead of a diversion option for youth so that they don't have to get to a place where they need that highest acuity. Another thing that sometimes happens is that a person might be kind of on the cusp of needing inpatient, but if the choice is inpatient or outpatient care as usual, a physician or a provider may choose to go with inpatient psych. And so having a good array of services in between is helpful to cut down on the number of inpatient hospitalizations. Gap area number 3 is a large volume of so California is implementing a large number of innovation and funding and accountability across access centers. So there's more scrutiny happening for your health plan, that's the Medi-Cal part. There's more attention being paid to how health plans are caring for people and how they're managing the data. You saw that in that external quality review EQRO report around saying, we want you to look at the high cost individuals, we want you to pay attention. And so our recommendation is that you consider implementing pieces around tracking wait times so that you understand not just the wait time around outpatient, which is right now a requirement for the state of California, but also understanding how long people are waiting for an inpatient psych bed. That is not a requirement of California, but it would help you understand how long people are spending in emergency departments and what that need is for people around getting care, particularly if they're having to wait to go out of county, and also understanding resources around that. The other piece would be, we would recommend that you work to deploy a forecasting tool to be proactive in thinking through what those resources are. And we have created, as I said, we've created several of them and are happy to do some handoffs if that's a recommendation that you would adopt, to be able to put those into your hands so that you can continue with your data-driven approach and be able to proactively think through what are those needs that are coming, as well as how many of the new resources that Medi-Cal is requiring you to create, how many you need to create. And the last one is a mismatch, and this is important. There's a mismatch between community and public perception and what the external quality review organization said around your access. So Ventura County Behavioral Health is meeting your access requirements and in doing a fine job of it. And your community is still somehow feeling that they don't have enough access to behavioral health. And you may hear that in some of those meetings and some of those places. And so why would there be a mismatch? Well, part of it is, remember, EQRO is only looking at the Medi-Cal covered population, and you have more than Medi-Cal in your community. That's one. Another is that as you all have been doing excellent work around increasing access and improving those things, word may not have gotten out to people who aren't getting, who decided not to come. Another piece is partnering with those communities of faith, those natural support systems that people have in their lives, to be able to get the word out around how to access care and how to get care, so that everyone who would want care knows how to get it. And so it becomes a bit of a PR piece, a public relations piece. How do we get the word out, and how do we get it out in a way that people find credible? It's always much nicer to have a PR issue than to have an actual access issue. But I think it's also important to understand there's sometimes a mismatch between what the state considers to be good enough. An appointment within 80 to 90% of appointments happening within 10 days of a first request is considered to be doing a great job. But if I call and I want care right now, 10 days sounds like a long time to me. right? And so helping people understand how did they get care. I love it that you guys shared the phone number to access. Actually, that was called out as one of the positives in the external quality review, saying that your access line is a best practice in the state of California. So let's get that word out to more people in more places and more ways. But also things like the access to the van and thinking about how you partnered with those federally qualified health centers to get people care in the places where they already are, will also help with that perception piece. So thinking about those partnerships. And the last thing that we gave you, and we won't necessarily go over it because we want to leave you time for questions, is we actually built you a high level roadmap around how to take these recommendations. We actually built sub steps for you around saying, what would it take in order to implement these recommendations in your community? What kind of pieces would you need to do for each one of those recommendations? So I'll stop there and give you an opportunity to ask questions.
Michael?
All right, good afternoon. I'm Michael Rodriguez. I'm the Chief Deputy Public Defender and one of the units that manages our mental health units, both within the criminal justice system as well as in the conservatorship realm. And I was looking at some of these numbers and if I just focus on the adults. In year 2024, there was 1,200 distinct members who were admitted into inpatient facilities. But yet, we have a total of 59 beds inside the county. That's 16 over at Horizon View and 43 licensed beds at Hillmont. So I'm seeing those numbers, and then coupled with the fact that the vast majority of our LPS clients, once they are conserved, are placed out of county. And so when I'm seeing that we need to have, 45 more beds, total of 45 beds, so just an increase of 5, that seems to fly in the face of what I'm seeing from an attorney perspective and representing clients. Now, I know there's some family members in here, and like their family members are almost always placed out of county because once they're conserved, we got 16 beds.
So I think the question is, you're saying that number seems really low.
Right.
So a couple of things. One, you will see on our high level, so on that same slide, it shows you upper bound, it shows you lower bound, upper bound, and then high level forecast. That goes all the way to 53.2. And so that's where we say your utilization right now is around 40. Right, an average of 40. And so if you were to keep at the same trajectory that you're at, you would only need a few more beds. But if you were to provide care for all who need it, that you would need more. The other thing, and this is where it gets a little challenging when you start talking about the math with beds, is that one bed is available for 365 days. And so as you add beds, sometimes people will say, I've got 10 people waiting, don't I need 10 more beds? Today, you might need 10 more beds, but then those beds are empty for the other days. An average length of stay is running between 7 and 14 days. For some people, it's longer, but between 7 and 14 days. So you think about what number of beds do you need for 365 days? So really increasing it to 53.2 or up to 45 gives you a lot more bed days within your county than it looks like by just saying we're gonna add 5 more beds. If that's helpful at all. I've got giant spreadsheets.
No, I understand the 53.
Yeah.
I still think that seems really low based upon our client population that we represent. We have much more than 53 conserved clients who are hospitalized involuntarily in facilities. And the vast majority are elsewhere. And conserved clients, they're hospitalized, we're not talking 5 days, we're not talking 10 days, we're talking months and sometimes years.
Yeah.
And so that's why I'm trying to reconcile some of the, the numbers, just looking at 1,200 inpatient, 1,200 adult distinct members with 53 beds covering that need.
So when you were talking about those folks who have a longer length of stay, they would actually be in your residential beds. So that's the 120.6. That's the 95 to 99 or 107. So when you are looking at this map and it says mental health inpatient, using the definitions for the data that we received, that's gonna be an acute stay. That's your short length of stay. Residential is gonna be your longer length of stay. And the difference between DMH and the mental health as DMH would be that there's a substance use disorder component to it. And the mental health is gonna be for primarily a mental health stay. So that's gonna be your, the ones that you're talking about would be incorporated in the 95 to 99 and, or sorry, 99 to 107, and then up to 120.6. If that's helpful.
And so on this here, you're saying that we would need over there anywhere between 99, a total, that we would need a total of 4 to.
You don't add those numbers together. The range would be 99 to 107, or if you go up to the top,
No,
one.
right now we have 95, so I'm backing out to 95.
Correct.
That's what I'm saying, you know, the difference between 4 and, 12.
Yep.
Beds.
Correct. Or potentially more, all the way up to that 120.6. And so this is where, that's why we need both models, the utilization model and the prevalence model, because just because these are the beds you're using, and by the way, this incorporates all the numbers of the beds that you're paying for out of county. These are the beds, you're using about an average of 95 beds over the course of a year at any one time, right?
So this includes out of county, these 95 beds include 90 out of county.
That's correct.
Okay.
These are the ones that you're paying for.
So if we wanted to have this local basic and we were to back up the 16 from the 95, just looking at today, then we're talking about 79. 79 more beds. Okay, that's making more sense now.
Okay.
Okay,
This is utilization, what you pay for. And then it's saying, how many more beds would you need to make sure that you have provision to buy, to pay for someone to be in?
and then when I say 79, it's in county beds. Okay.
Yeah.
Thank you.
Yeah, I think what he's going towards, what Michael's saying is, where I think we all, the goal is to bring more of our inpatients in county. That'd be helpful to know those numbers. How many in-county beds do we need to bring online, especially for the youth, but everybody, how do we keep them in the county?
And the way you would do that is you would take the number of in-county beds that you have and subtract that from these numbers, and very quickly you'll get the number of in-county beds that you need. To be able to say this is what our in-county gap is. Building beds.
There's 16 in county.
That's correct. This is adult, I'm asking adult, because that's the only hospital for LPS in conserved time is Horizon View. They'll take some Mercy conservative teams, but it's Horizon View, because we see clients waiting at Helmont who've been conserved to be placed elsewhere, whether it's Horizon View, which is always full. And then, they typically go to Los Angeles, or Los Angeles, Stillmar, Kern, or San Diego.
So one of the things that the tool that we built for you, it's huge, it's a very big tool that actually can get down to that level of detail to be able to say, all right, how many beds do we have in county versus out of county? What's going on with those pieces? And so that's actually one of our recommendations, is that, we would love to be able to do a handoff with your team to be able to say, this now is your tool. You can use it to do scenario planning. That this says, how many beds do you need to have access to, but you can actually titrate it down and say, how many beds would we need to build specifically here? That you could use this tool to be able, the other thing that is helpful is that right now, this is saying, based on the utilization that you have right now, as we shared, Medi-Cal is changing, Connie, every day, right? Almost, I think Dr. Dennering is out at a meeting right now, learning about new changes as they come, right? And so by having something that you can scenario plan and put new information into, and then it spits out another outcome, and it says, all right, we actually think we're gonna have more people because there's something different going on in the community, there's a different level of care that's being offered, we think more people are gonna come and take us up on these offers for care, you can actually scenario plan and put in a different percentage, and it will actually spit out a different number. It's very interactive, and you use it then to contingency plan and say, if this, then that. If this, then that, and you can actually come up with your own upper and lower bound ranges to be able to say, if our waiting list has 50 people on it, but we expect our waiting list to have 100 people on it coming, how will that impact the number of beds we need? Total, and then also local, if that's helpful.
We have a question from.
Yes.
If that's fine, if we could see the total of the people who are on Zoom, so we can pick up the questions, that would be helpful. You don't need to see all of us so much. If there's a way you can do that, just, but who did you say was?
Liz Warren.
Oh, Liz Warren, okay, Liz, sorry, we're having trouble seeing the people on Zoom, so Liz?
Hi, thanks so much. I just wanted to add some additional information that might be helpful. I don't think when they were looking, they're looking at utilization rates, and they're not looking at things that are in the pipeline right now. We wrapped up the RFP process for the MHRC out on Lewis Road. So there are 38 beds that will be going online within the next coming year, later this year into next year. So that process has been completed and it's in the works. So I think when we're looking at this, because you don't have those numbers in front of you, I just wanted to point out that in fact, there are 38 beds that will be coming online. And I think the important thing, and this has been a discussion within the department, is that the provider of the new MHRC has to give priority to in-county placements versus taking out of county placements. And I think as all of this comes online, there's going to be perhaps a different approach taken so that we can capture all those in-county beds for ourselves. So I don't know if this helps Michael, but I just wanted him to know that there are 38 beds that will be coming. And we're also looking at the PUF out in the East County. We're looking at the CSU. There are additional things in the pipeline. They're not going to necessarily stem or mitigate some of what we're looking at now in real time, but I would say within the next, 9 months, there's going to be a substantial 8 to 9 months will be a substantial difference with our ability to take folks in county, maybe even sooner. I don't want to speak out of turn though. And I don't see Loretta in the room. It's hard for me to see who's in the room, but I just wanted to add that information to the conversation. The other thing I just wanted to say in terms of making a comment, the mobile unit is an outreach. It's not a mobile clinic. And I think people need to understand the difference between an outreach unit that is providing access and assessment and linking folks to services versus a mobile clinic. It's not the same. So I don't think it addresses the gap of services of having a provider in those areas of the county that were on the map that showed where there wasn't an actual psychiatric provider. They will provide links to services, but that would not solve the problem of not having a provider in that area. That's the comments that I wanted to make. Thank you.
That was really helpful context. Thank you. And you're absolutely right. That's actually why you want to think about a forecasting tool to be able to say, the scenario right now shows current utilization and projected utilization, assuming everything's the same. As your situation is fairly fluid and is changing and evolving, you're going to want to have something to be able to do scenario planning to say, these beds are coming online. We're going to be able to do this. We expect this demand to change. We're doing something upstream, so we're expecting fewer beds to be needed downstream. That those are some pieces you want to be able to be nimble with.
Andre?
Just want to comment, I think we're all familiar with how placement works. I work in the hospital and PCMC and pediatric ward at the pediatric hospitalist. So from my end, it's challenging and inefficient. It's just the beginning. These families are waiting for placements and waiting. What you don't see in the state is how many extra days these kids will have to stay in the hospital waiting for a bed. In some cases, up to 4 to 5 days extra, just over sitting in limbo. And also what may not be reflected here is cases where families decide on voluntary placement. And then when they find out that the only beds available is Bakersfield, you can imagine what they think about that. And so they change their mind and say, okay, no, we're going to just work on outpatient when perhaps, an inpatient stay would be better. So, yeah, and then the way it looks like who's on the ground is, it's like a cat and mouse game. We're competing with other centers to try to get the patient, and we're faxing information, we're waiting for the exact time, we know that the bed's gonna perhaps be open, it's a mess.
I'm really glad that you brought that up, because that actually was one of our findings, right? Is that because you're not tracking, and again, you're not required to, right? This is more of a best practice. Because you're not tracking the amount of time that people wait for that inpatient bed. That is not reflected in this data. When you start tracking, if you were to start tracking how long people wait, there's actually a multiplier that goes in that says how many people are waiting and how long do they wait? And how many more beds do you need to close gaps in your current system versus how many beds are you expecting to need because of growth of population or growth of need and growth of prevalence, right? And so this is an invisible number to you right now because it's not being tracked. And again, no harm. I mean, look, you are not required to do this by Medi-Cal right now. What we're suggesting is that it's a best practice to start gathering that data so that you can use it in your forecasting. The other thing that we have seen across the country around what to do if you can't, while you're trying to build beds or when you don't have the beds within your county, is you can pay for some capacity. You can pay for some beds to be held on behalf of your county. You're basically paying for that bed to be empty so that then in the emergency department, when someone has a need, you call and say, I need one of the I need a Ventura County bed. And if that bed's available, now you've got a spot for that person versus competing both on cost and on acuity and on all kinds of other things that people don't like to say out loud, for being able to get that bed, right? And so if you say, we're willing to set aside a certain number of dollars that we pay for a bed to be held on behalf of the county, I wouldn't do a ton of them, because you don't wanna waste money, right? But you could do, and those forecasting tools can actually help you figure out how many beds you wanna buy, to be able to say, we wanna hold these beds just for our folks, so that LA doesn't get them, so that San Diego doesn't get them. So it's great fun.
Did you, in all this data are you able to identify people who are using these resources who aren't from Ventura County?
So none of these data include people who are not from Ventura County. So the data that we looked at comes from your health plan, what you are paying for. So that's where your Medi-Cal covered population. And then the HPI data talks about Ventura County residents, regardless of payer and where they're being hospitalized. So all of this data are your residents.
So if there were people though who were being housed here for whatever reason from other counties and taking up our beds, you would not have that in this.
That's correct. That would be invisible to us.
It's only what.
Yeah, this is what you pay for what the HPI, which is the healthcare information, data information, bulk payer database for the state of California, has identified as someone who is a Ventura County resident who was hospitalized and a claim was submitted on their behalf. So these are only Ventura County residents. Now, if there's a person who wasn't willing to share where they're from, who's Ventura County, they would be invisible in this data because there'd be no way for any of the payer sources to know. But for the most part, they work really hard to figure out where someone is from because they were trying to attribute them to this county or that county.
So in this, the tracking devices that you're proposing, would it weed that out? Would it be able to show us that?
So the forecasting tools that we built only show you Ventura County residents. So yes, this is only going to show you the tools that we built for you, look at what you pay for. So it doesn't matter where you pay for it, it matters who you pay for, and it's Ventura County residents who are covered by Medi-Cal. And so that helps you know who I'm on the hook for, who I have to pay for, and who I need to make sure. I wouldn't recommend, by the way, that you would buy beds for non-Medi-Cal residents and for non-Medi-Cal beneficiaries. Because you have a need to meet the need of your Medi-Cal first, and then you need to think about whatever those other pieces. However, this is where we said from an outpatient standpoint and from kind of a larger system of care, you have a portion of your population that is struggling to get access, whereas your Medi-Cal population has a little bit better access than your non-medical covered population for some of these outpatient services, just based on the map that we saw about where the providers are. The nice thing about your Ventura County, both directly operated and the contracted, is that many of them accept all insurances. So where you see a Ventura County resource, if you don't have Medi-Cal, you can still get care at some of those places, right? But if there is no triangle or square, if there's nothing, there's nothing there. And we looked at the NPI, National Provider Identifier databases, and we looked at, where resources are nationally, regardless of payer, and that's, I mean, you have some deserts, you have some resource deserts.
Yeah, and can you, or have you identified, separated out the ages in terms of beds? Because we're talking about the number of beds needed, but it looks like youth is really underserved in all ways.
Right.
And I like your idea of more daycare, or not daycare, but day treatment for youth as a possibility of those. Some of them might be useful. Do we have actual, and you might not know this, but maybe kind of just, do we have day treatment on a, like every day somebody comes in and they get treatment, but they go home at night? Do we offer anything like that?
All right, now.
Yeah, and one of the things that having something like that can do is, one, it does give that opportunity, as I call it, an off ramp. It's an opportunity to do that instead of inpatient, if it's safe. I'm a licensed clinician, I don't want you to go there if it's not safe, right? But if it's safe, then that's an off ramp, but it also can shorten an average length of stay in acute care, because the acute care hospital knows I've got a safe place to discharge Allie Franklin. She's gonna come back and be seen intensively starting tomorrow. That's different than coming to outpatient care as usual. And so we often see that it can shorten an average length of stay for an acute care stay, because then they're doing just the acute care stabilization, and they know skill building and skill acquisition and skill support, that can be done over here. And so you see people being able to be reunited with their community more quickly, and so therefore their families are less stressed about having to go out of county, or how do I go visit my family member?
Is it cheaper?
It's cheaper to build, right? A bed is expensive and it takes time to build.
Right.
Which is one of the reasons why we're trying to work together with you to say, yes, and, right? You're saying I wanna bring more resources into the county, absolutely, and what do you do between now and then? Also, you might not have a provider who's excited about building a brick and mortar hospital. And so it can be difficult to cultivate those beds, and we also know it just takes time to build a hospital.
Thanks, Andre.
Does Medi-Cal pay for partial hospitalization programs and intensive outpatient programs, like what the programs that we're referencing?
So you have to look at the particular codes, they have to meet medical necessity criteria, and they have to be meeting a certain level of service intensity. So I would say, yes, with caveats, it's not simple, but it is absolutely possible.
It's like day treatment, like 20 hours, right?
They actually generally call it day treatment,
Partial hospitalization is a term used on substance abuse, but as day treatment, we can do like 20 hours of services. And I was just gonna comment that in substance abuse, I know I have Dr. Davis here from substance abuse, there's what is called recovery residences, where folks in substance abuse can come to treatment during the day, do their AA meetings, et cetera, like that. And then they go to the sober, they will call them sober living environments. They're not locked though. So I think it's good for us to talk about the different populations we're talking about, a locked facility versus an unlocked facility, on the different folks that we serve, so.
Thank you. Sylvia?
Yeah, so with the new changes to, I'm not sure if it's Prop 1, but the 5150 to allow the not really, but the co-diagnosis of substance abuse. For a long time, that was a cause not to be able to 5150. So now that that is allowed, and we should be able to increase the 5150s, is that included in his data that we are not going to be able to have more people, 50 under those that you will.
So the answer is no, it is not included in the current data, and that's one, this is actually exactly why we suggest, you can use our tool, you can use someone else's, I'm not trying to sell you anything. You've already paid for the tool, frankly, we had to develop it for this, so, it's really around, that's why you would want a tool like this, to be able to say, I wanna do scenario planning. I'm expecting, this is based on what the utilization is and what the prevalence is in your community, and again, that map, right, my three-legged stool here. But we're expecting something to change because Prop 1 has changed, because the 5150 rules are changing, because you're going from MHSA to VHSA, we've got VH Connect coming, they're all, things.
That's
Right, so that as these changes happen, that's where you wanna be able to put this into a scenario planning tool and have it say, what you thought you needed in everything is normal is this. But everything is not gonna be exactly the way it was last year or 2 years ago, it's going to be something different. Great, I wanna put in a different scenario, and then a forecasting tool spits it out and says, here's what a low range would look like, here's what a high range would look like, and that allows you to be nimble and responsive in a way that right now, by only looking at the past and not being able to put in a scenario, you're having to kind of, you know, put your thumb in the air and go, I think maybe we're looking at possibly this. Whereas this is actually using a data-driven approach, which matches up with how you all were recognized by the external quality review as having some strengths in. It allows you to use your data-driven approach to forecasting and thinking through planning. And you can say, we think it's gonna be this in year 1, and we actually think it's gonna be this in year 2. You could actually build a forecast that says, I wanna see what year 1 looks like, I wanna see what year 2 looks like, I wanna see what year 3 looks like. Which helps you build.
Is that like based on age that you know that someone might be 17 now, 2 years from now, they'll be 19 that you forecast that, or?
Or it could be based on we're ramping up services or we're ramping up screening. I'm thinking about, so in the outpatient world, right? So the BH Connect is causing you to think about centers of excellence. If you build it, sometimes people will come, right? And so when you think about adding more service levels and service opportunities for people, your penetration rate might actually go up. You might actually have more people take you up on services than you did before. And so you're going to need to be able to scenario plan. Half of our clinics are up with it in year 1, so we only want to expect half more people would come. If we think by year 2, 100% of our clinics would be up, we need a scenario plan for that. We think by year 3, we'll have gotten the word out, because we also know getting the word out takes a long time. It's just, you know, people, humans, right? We need to hear information 7 different times, 5 different ways, all kinds of ways to get it anchored into our brains. It's just the human thing. And so as we're getting the word out, we believe the uptake might increase exponentially by the time we get to year 2 or year 3. You can build that in your scenario plan, if that's helpful.
Are there any more questions? Michael?
It's more of a comment than a question, and I wasn't, like, I applaud behavioral health for making progress and having new beds in the pipeline. But even with new beds, we're still talking a shortage of about 40 for residential care beds. And so it's just a reminder, it's not a critique on the department, because we've had these discussions a lot over the years. It's more like, how are we allocating resources as a community? And, you know, how are these different communities prioritizing the need for this? Because we, not only there's always the, you know, the perpetual money issue, that there's never enough of it. We also have budget with NIMBYs in many communities. And so it's like, it's a two-headed monster that, you know, that systems are trying to confront when trying to address the needs of the community. So like, I'm not, like, I agree with this as far as progress has been made, so I didn't wanna dismiss that, because it's bringing on 30 some odd beds is great progress, but it's just a step in the right direction.
Yeah, good point, thank you. And, yeah, go ahead, Mary.
This tool that you keep referring to, you built this for ECDH staff to use. So specifically, it's a piece of software, imagine, or is it web based? And the second question is really, who's gonna be using it and how will we get updates on it as to what is really needed so that we can ask them questions later?
Wonderful question. It is an Excel spread, it is a really big Excel spreadsheet with lots and lots of tabs. And, how we would envision, again, if the board recommends that you do that, and again, there are other tools, right? You know, I'm not trying to sell you anything, we built it for you, you already paid for it. Is that we would hand off and train that tool to the health plan, both the finance side, because what you pay for beds, but also how many beds you pay for. And we would train it to finance the data, but also to health plan, to be able to say, how do we input data, and then how do they become stewards of it? That you wouldn't need us long-term continuously updating it, we actually would train you and teach you how to do that, and then I would imagine that the recommendation might be to say, could you get regular updates from the health plan to say, you know, you're looking at the forecasting, is there a change? Or how does this new thing that's happening in California impact our supply and our need? Will this drive our demand up, so we're gonna need more resources? Were we as successful at bringing in more beds to the community, or are we still outsourcing them to other communities, and what do we need to do? And so you can bring that back to the health plan and say, help us talk about, what does this mean? What does this mean? And the other thing, and this is where you guys got a data nerd, I love data. You can also measure your success. You can actually quantify, are we making progress? Are we closing the gap around these resources, or are we adding beds at the same time we're adding demand? And so even though we've added beds, yay, we've added demand at twice the rate, so we actually accidentally lost ground. Or are we adding beds faster than what we have and we're gaining ground, right? Like either way, and again, not in a value driven way, but in a data driven way, to be able to say, are we making progress?
And this is not just county money, it's federal money, but with these wellness centers and some of this money being taken away, it just seems to me that we are going to be adding to the need at a higher age, because we're taking away services at a younger age. So it seems like we were just getting somewhere, and now we're wiping away that early intervention progress that might help us need maybe drop-in centers for youth as opposed to beds for adults.
I agree with you completely. But the other piece, and I'll tell you, a lot of communities are beginning to see federal block grants feel like they're at risk, right? And so we are seeing more communities working towards what are billable services, what are Medi-Cal billable services, what are HRSA, you know, the Human Health Resources and Services Administration funds, which come through, you know, so you think of HRSA funds and those kind of things go to FQHCs, federal qualified health clinics. And so what are billable paid services that we can build and add to our community, because those grant dollars may be more scarce, more difficult to find, and feel less like something we could count on. Whereas some of those other dollars are encumbered and required, and so would be harder to pull back. Not impossible to pull back.
Get pretty good at it.
But harder to pull back, whereas a grant dollar right now, we have seen, is easier to pull back.
Right. Okay, I think in the interest of time, although this has been terrific, and really, thank you so much. I think what you provided us with is a lot of good data that is, and you rated, you know, explaining it, so it was easy to understand. Hopefully, if I got it, most people should be able to get it, so I think it's good. But thank you so much for all the work that you all are doing, and this tool that I don't know where the department stands on that, and obviously they make that decision, but it sounds encouraging, because you're gonna have to, with all the changing things that are happening, you know, at the national level with funding, et cetera, you're gonna have to be able to be nimble and looking at projections in a new way, so I think that this sounds like it would allow us to do that, so thank you.
Well, thank you, it's been such a pleasure working with all of you.
Thank you.
So much. Okay, we're moving to board comments. Does anyone have a comment they would like to make? Seeing none. Sorry.
Yeah, I just wanted to add, like, I know we don't have our ad hoc committees anymore, but, that doesn't stop us from talking to each other, so I'll be here a little bit after the board. If anybody wants to like form a coffee group or talk about some of the issues that we're having, that's totally allowable. Outside of an ad hoc committee, so yeah, I'll be here and I'll be hopefully to talk to some new people. Thank you.
We will have ad hoc committees, but we won't be starting until September.
Yeah, no,
Yeah.
thank you. Interesting stuff today, obviously, still getting my arms around everything, but I was reading that, the letters that were submitted, living in Simi Valley, having a middle schooler myself, and this is a theme that I have seen come up. There's articles about it time and time again, and when he brought, I would be interested in exploring it as, a board or getting some input on this idea that, hey, you can walk into a smoke shop and get all of these types of, what I've read in the articles is basically alternatives and deviations for any kind of existing drug that are being openly sold in smoke shops, throughout the county. And I thought it was interesting, especially again, having a son that's in middle school at Simi Valley and hearing a, 8th grader talk about this and being, aware of it. I actually think it is a real big, threat, and somehow they found, loopholes around, selling, products out there, and I think we have a big impact. It seems to be expanding. So it would be just reading those letters, maybe say, what are we doing about that? What is going on? What enforcement is there out there? What options? Or is it just, hey, they live in a legal in-between gray world that there's nothing you can do about it?
Unfortunately, we have a member of the sheriff's department who is a member of the board. He's unfortunately not here. He's, I think on vacation, right? He's not here today, obviously. So, it is a good question, and maybe we can ask him to address that, when he's here, which I think should be next month. I think he told me to be here next month, so I'll double check. Maybe. Oh, definitely, the letters, yeah. Well, he got them because he would have gotten the packet, but perhaps we could ask him to address that next meeting, so we'll find out. Yeah, thanks for bringing that up. And I thought there was someone else who, no. Okay, great, okay, old business, there is no old business unless somebody else has some. Oh, go ahead.
We had talked about site visits, and that's kind of an old business thing. I tried to make visit if it was a Kilbot, and then they had a COVID outbreak, and so we canceled it. But I know that Daniel and I went to Tonga Jail, for a part of our BCLA tour, and I said to Shane, if we come back with our forms and Philip, we were kind of done half of it already, so we could probably get that one done pretty quickly if we wanted to just get that going again.
Okay, well, I think it's just coordinating it, we're gonna jack it anymore, so it's coordinating with the staff of who does that. Yeah, okay, good suggestion. Okay, anything else? Okay, a new business just quickly, next month, we are gonna have a general meeting, obviously, and we will do some business, which we've just talked about a couple items that will probably come up, but really the majority of that meeting is going to be orientation. And this will be because we have several new members, plus it's always a good reminder for the rest of us, so we will be having Teresa Comstack, who is the executive director of our state organization. She won't be here in person, but she will be on Zoom, and she will present to us things such as a role of the member of the board, of this board, and what the WIC is, etc. And a lot of us have gone through this before, but it's always helpful. We will put that at the end of the meeting, so people who feel like they don't want to stay or can't stay for that, they don't have to, but it will be available for all of us. I did ask at the executive committee, I'm gonna ask again here, if you have any specific topics you would like her to address or questions you know of now that you would like her to address, please let me know. You can either do it now, or if it comes to you later, please contact me and let me know. I will be talking with her at the end of this week about her agenda for our meetings, so whenever you might want her to also bring up an address, please let me know, and we'll make sure that she does that. Okay. If there's any presentation requests, you know, again, or recognitions, let us know, either the staff or myself, or we encourage you to be looking for community partners so we can give recognition awards to contracts. We had quite a few. And yes, so
So can we get a list of past awards so we know that we're not recommending another person? Or is that too hard?
I don't know, and you look, okay, she'll look, I don't know the answer to that, maybe from Jackie or something, yeah, okay. Contracts, anybody have a comment on any of the contracts? Anything you wanna ask a question about or make a comment on? We had quite a number, actually. What is the beginning of the new fiscal year, I guess that's why.
Sorry. Okay, I just want to come on Nate's place, that is a drop off center for you, then I'm just happy to see that with that, the contract for that. Decent size that they can.
Yeah.
Serve them.
Okay, again, it's public speakers. If we have any additional public speakers, and again, I apologize to the people who are watching who we can't see. So, but I think we can hear them, right? Selena?
Nobody has a hand.
Nobody has their hand up, okay. Anybody else? Yeah, go ahead.
Jan Balbani again. I understand that, Dr. Derry talked about improving the sound system over here. But I just wanted you to know, when we're on Zoom, really don't hear folks clearly unless you're speaking into your microphone. That's one of the reasons I actually want to come and attend this meeting in person and drive all that distance so that I can hear you clearly. So if you can be mindful of that until a new system comes into place, and not speak from 10 inches away or something like that, maybe about that. Thank you.
It's a great reminder, thank you for driving over to attend the meeting.
And then I had one more correction to the. And we late, one more correction to the minutes. Tracy Holt is with the Ventura County Emergency Medical Services, not county healthcare. And I'll bring it.
Okay, she can put that into the, and it's although we did approve them, but I think we just add that in, just so.
I guess it's been this way a lot.
Oh, okay, okay. Anything else? All right, thank you for sitting through this meeting with two really good presentations. But I think it was something that we needed to do, and I'm glad we got to do it, so thank you all for coming, meeting's adjourned.
And